My name is Cary Gross. I'm a professor of medicine here at Yale, and I'm part of a large team of collaborators and researchers that include individuals from the Connecticut Department of Health, Department of Corrections, and also here at Yale. Our group as a whole is very interested in understanding and improving the care and outcomes of people who are incarcerated with a focus on cancer. Prior work has suggested, in general, not just cancer related, there's a time period both during incarceration and also within the first couple of months after release of incarceration when people are exposed to increased risks to their health. Sometimes the transitions back into the community can be particularly challenging for people to get plugged into healthcare and the medical care that they need. Other studies have suggested that during the time that people are incarcerated, it can be challenging to access healthcare sometimes. So our team is focused on overall mortality for patients who are diagnosed with cancer. And in those older studies, what we found is that patients diagnosed either while incarcerated or during the first year after release from incarceration had a higher risk of death than the general population of patients who have cancer, but no history of incarceration. So that led our team to want to dig a bit deeper into what might be the cause of these different outcomes. For this study, we focused on the quality of care people are receiving. So after a diagnosis of cancer, are people getting the care that is recommended by guidelines? What we found was that there was a relation between incarceration history and the quality of care. So what we did is we matched people who had been diagnosed with cancer in a certain time frame according to where they were diagnosed. And what we found was that, broadly speaking, people who were diagnosed during incarceration, about half of them received the care that was recommended for them. And these are different types of cancer, breast, lung, prostate, etc. So half of people diagnosed during incarceration. But we found amongst people who were incarcerated but then were diagnosed afterward, in the year after incarceration, only 45% were getting the recommended care. So both of those groups, 49% while incarcerated, but 45% after incarcerated, ended up having a lower likelihood of getting recommended care than people who were diagnosed out in the community, and that group was 67%. So there are two main findings, two main inferences here. First of all, if you just leave incarceration, leave that bucket to the side for a second and focus just on the broader population here in Connecticut, 67%, only two-thirds of people are getting all of the care that's recommended for them, guideline concordant care. So overall, in the general population, there's plenty of room for improvement. But now the other two groups, current or recent incarceration, both of them had a lower quality of care. And that suggests that maybe it's not just the issue of whether someone's currently incarcerated, but maybe the underlying social challenges and challenges accessing healthcare that may be associated with incarceration that are driving some of these challenges to accessing care. So two take-home points. There is a relation between incarceration and lower quality of care, but it's not just because you're incarcerated. Again, it's because we think that the same factors that are associated with incarceration, such as less likelihood of having health insurance or being exposed to racism and a lack of feeling comfortable or welcome or getting high quality care in the health system could be barriers. And the other major take-home point is that in the larger population, there are gaps for everyone in getting the quality of care that we need. Our study focused on the straightforward question of what proportion of patients were getting their recommended care. So we were not able to understand the why, unfortunately. That's, I guess, the key next question. Why are people not getting the care that they need? For people, particularly during the time period after release, again, being connected to health insurance, being able to have a primary care doctor, being able to navigate the healthcare system, Also, I've been thinking a lot recently about this issue of time as a barrier to healthcare. And what I mean by that is people frankly, are just trying to live their lives, they're trying to work often hourly jobs or looking for jobs or finding enough money or resources to pay their rent. It's hard to go and take the time to figure out how do I even find a doctor or a cancer center or go sit and wait for 2 hours or 3 hours in a clinic. And as opposed to people with more resources, they have cell phones, they have emails. It's easier to make appointments and get access, but also they can take time. You take paid time off of work, paid leave for an illness. So I think part of it is this issue of time as well as issues of overall access are important barriers. This is not part of our study data, but even for people who are incarcerated, the issue of time plays a role in that it can be harder to bring incarcerated individuals to the hospital or to the oncology clinic. That can also cause some time constraints. One thing, as far as a step forward, that we've found to be really helpful is having willing and engaged partners, such as here in Connecticut, there's a wonderful Department of Corrections health team that's really interested in understanding and learning what is the quality of care that we're providing and how can we brainstorm around improving it. As a take home for all practitioners, all clinicians who are thinking about oncology, we frequently have access to our own population data with regard to looking at quality of care and access and timeliness. It's something that having a eye towards continuous improvement and thinking about our patients as being parts of communities and populations will really serve us well. First of all, one key consideration is to think about what are our own biases, both when it comes to how patients are being treated when they come into the healthcare system. Are they being shackled? And we've heard, again, not from our study, but we've just heard anecdotes of people who are getting chemotherapy, getting palliative radiotherapy at the end of life, who very poor functional status, and they're being shackled to their bed when they're clearly not a threat. And some of these people are really suffering and can't even stand up. But regardless of their functional status, we really have to ask, do we really have to make people feel stigmatized at each and every step of the way within our healthcare system? I think as clinicians, we can ask ourselves the tough questions about how are people, patients, not prisoners, but how are our patients who are under our care being treated? And how can we ensure that they are feeling supported and supporting their humanity, particularly when confronting a serious diagnosis such as cancer? And there are challenges with regard to health literacy of the broader population, and certainly amongst people exposed to incarceration. So trying to think through how can we better communicate in a clear and understandable way. What are the treatments people are getting? What are the risks and benefits? Is it possible to bring in family members? Because I mean, everybody forgets what you're told at the doctor's office. We often say that, on your first visit after a cancer diagnosis, that you hear the word cancer, and then everything else is just like shut out. I mean, understand it's just a human nature thing. You're kind of just blown away by this diagnosis, and it's hard to remember anything. So I think for everyone, but including people who are incarcerated, figuring out, is there a way to engage family members or loved ones to help them to navigate the system, and both asking questions, but just frankly remembering what the next steps are, and also obviously supporting the patient and caregiving and just emotionally supportive way. The next steps for research, I like to think about these two groups of patients separately when it comes to research. So first of all, when it comes to incarceration, one aspect of cancer care that would be wonderful to have an impact on that we haven't really talked about yet would be cancer screening. So identifying interventions to improve awareness and engagement and hopefully cancer screening rates amongst people who are incarcerated. Because there are some types of screening, FIT testing for colorectal cancer, mammography. Now there's, self specimen collection for cervical cancer screening. a lot of these types of screening tests could be readily applied in the carceral setting. So if there's a way to identify interventions to improve access to cancer screening, with an eye towards prevention, that would be terrific. And frankly, not only cancer screening, but also education about the importance of screening and cancer prevention. So when people are released, and most people fortunately are released, that they'll have even more awareness and comfort navigating the system and understanding the importance of cancer screening. So that's the incarcerated population. And then I mentioned earlier, there's this time period after release, like within the first year of going back out into the community, to identify ways to engage patients into care, into primary care for prevention, or working for people who have a cancer diagnosis, making sure they're getting plugged into the system. So we're working with one of our team members. Emily Wang leads a large center here called the SAISH Center, and they have a wonderful network, the Transitions Network, that is already at the national level across multiple cities, engaging people post-incarceration into different aspects of healthcare. So what we're thinking of doing is, can we expand those initiatives to focus on cancer screening and prevention? And similarly, Alana Richmond, another collaborator and the lead author of this study that we're talking about, has been looking at interventions to improve cancer screening in the carceral setting. So we have irons in the fire in both of those domains. When thinking about populations at risk for adverse health outcomes, the criminal justice system is unfortunately a great place to look. I mean, there are millions of people in the United States who are either imprisoned or somehow under the supervision of the criminal justice system. So this idea of mass incarceration is not only robbing people of freedom, but also robbing people of health. So as we're thinking about ways to improve health and improve health equity and make America healthier again, one key thing for us to consider is, what are we doing with regard to mass incarceration? And there, in the past 10 years, have been some very small incremental movements toward trying to decrease the degree of incarceration. I'd hate for us to go in the wrong way, because on the one hand, if we're trying to make America healthier, we shouldn't be overly criminalizing every aspect of American life and increasing the number of people exposed to the toxic environments of the carceral system.